Yeah, thank you very much. Assalamu alaikum, good morning. It's always a pleasure to be back in Karachi, which feels like one of my hometowns. And the moment I land and I smell and I see the chaos in the streets, I feel back home. So I was asked to give a talk of about 10 minutes about workforce and quality. Healthcare is a different kind of business than any other one. As you heard, I'm trained as an economist, and you learn that there are two elements in creating value. One is capital, and one is human labor. And capital is in terms of machines, infrastructure, and labor is, of course, trained workforce. In healthcare, there is another element what most of the time is not fully recognized by management, and that is the factor emotion. Because we should understand, healthcare is different from banking and is different from manufacturing a car. So for example, a car is a matter of machinery, and actually currently the human element, humans in manufacturing cars don't exist anymore. It's almost completely automated. So this production process is human-free, purely based on capital. But in healthcare, we still rely a lot on management of humans and managing emotions. Because going into a hospital comes with fear. And it took me 25 years to understand that everybody who comes into a hospital or any healthcare institution comes with fear, because you don't know what's going to happen. There might be an injury, there might be an organ failure, there might need to be a procedure that will disrupt your life or of your family member in a way that you don't want to happen. So keep in mind, when we talk about healthcare, it's always about capital. We have expensive machineries, scanners, ICUs, operating theaters. We have humans that cannot be replaced, and I come back on this one later, and there is the factor of emotion. And the interaction between these three defines your outcome. Now, looking at the situation currently in Pakistan, the facts are that there is a severe shortage of nurses and allied health professionals. The World Health Organization recommends about 4 nurses per 1,000 inhabitants, and Pakistan has about 1.1. So the factor humans is actually not up to par. Many hospitals have a high physician to nurse ratio, and that leads to an underuse of mid-level providers. So the contribution of nurse practitioners and physician assistants is not available. Many of our skilled nurses move away out of Pakistan. And it's very difficult to get them back because we cannot match the salaries that they earn in Qatar or Kuwait or wherever they go. Also in Pakistan, when we look at the education system, we don't have enough accredited programs for advanced nursing, biomedical technologists, infection control specialists, and people that care about patient safety. Compensation is rarely linked to outcomes or quality metrics. I'll come back on this later. And unfortunately, and many people in nursing are aware of that, the hierarchical situation in hospitals is not always one that stimulates growth and equity. So these staffing levels that are below par have big impact on higher infection rates, longer length of stay, and more adverse events. And everybody in nursing is aware of that. Competence is not just degrees, but it's also continuing training, certification, and many hospitals don't provide continuous education as a habit, and it should be reinstalled as that. So many people suffer from stress, burnout. Many people feel underappreciated, and for that cannot provide compassionate care. And I'm sorry to say, in many hospitals, the hierarchy does not stimulate teamwork. So the talk of the day is artificial intelligence. If people assume that artificial intelligence will replace the work of nurses and doctors, I think that will not happen. AI might help to reduce admin staff. It might help to simplify billing. It might help simplify coding, but it will not help to compensate for the shortage of nursing. It will not. Because the emotion factor, which I mentioned as an important element in the healthcare industry, cannot be taken care of by artificial intelligence or computers. I've seen robots in China walking. They might be able to wash the patient, but even that, I think, is a nursing act that gives you the opportunity to do observations, to signal issues, and to inform physicians, okay, we might need to pay attention to something that we so far did not observe. So, in my opinion, all the talk about artificial intelligence is more about support, clinical decision support. Like we know, for example, that in radiology, artificial intelligence helps the radiologist to be much more accurate than before, but it will not replace. There was a very interesting article on October the 2nd in the Dawn newspaper, written by Sir Malik Jalal, who was actually not somebody familiar in healthcare. And he gave an analysis, what he called the Pakistan nursing gap. It's a very interesting article. And he states, okay, there is a shortfall in Pakistan of 620,000 healthcare professions, mainly nurses. Most of the graduates are undertrained. There are weak regulations for nursing colleges. Some nursing colleges in Pakistan are very good, but the vast majority are below par, despite many efforts of the people working there. When we look at what happens, there are faculty shortages, and many faculty are not fully qualified. So imagine what that means for the standards of the graduates that they deliver. They have a lack of skills, both in the technical nursing field, but also in the soft skills when it comes to emotions, psychological, and communication. And so he states, and I agree with that, these underqualified graduates are actually a liability for the healthcare system in Pakistan. And he suggests, okay, what should happen is a better and more radical regulation of education and the standards as practiced in these nursing and medical colleges. We should do more on faculty training. We should impose strict accreditation of nursing schools and nursing colleges. We should actually think of some kind of creative destruction to see if we can change the way we educate and train nurses in Pakistan. And we should much more invest in public-private partnerships, because most of the nursing colleges that are good are in private institutions. Now, further, a few observations on workforce and quality. In many government institutions, as per my personal observations, consultants run private clinics in the afternoon and in the evening. So that means that after 2 or 3 o'clock in the afternoon, hospitals are run by juniors. And imagine what that has implications on the quality of care provided, and also the impact of this on the collaboration between nursing and physicians. And then basic standards are not always met, despite efforts, because it's not that people don't work hard, It's just that the system doesn't help them to provide the optimal output. And there are many smaller private setups that meet standards only partially. So many people have small hospitals and try to do their level best, but are not able to manage standards of any kind. Too many institutions are too much focused on revenue. Money is a big thing in healthcare, especially in the private sector. And not always there is a proper balance between focusing on revenue and providing quality of care. And you can imagine who is suffering from that. Management is not always competent. Being a good doctor and starting your own setup doesn't mean that you are a good manager. And it doesn't mean that you are able to create teamwork. So in many of these institutions, we observe low morale and a high level of individualism. Hygiene standards, because of the lack of training and the lack of systems, are often not met. And for example, medication safety. I did some research, and I hope to publish that soon. In the US today, about 150,000 patients in hospitals die of medication errors. Wrong calculations, wrong dose, you all know the story. I suspect that the number in Pakistan would be close to 1 million. People who die in hospitals because of medication errors, because the system, the education system, does not provide the knowledge and the depth to make sure that this would not happen. And finally, talent is not groomed. I'll give you a few examples that I observed myself. And this has to do with the way we organize our institutions and how we establish hierarchy. So if you are a very senior person, professor or consultant, and you have younger people working with you, your job is to make them better than you are. My practice is when I appoint somebody who is potentially better than me, myself, because that would be my legacy. But what I see in many institutions, that if let's say I'm a good doctor and I'm very well done in doing certain surgeries, and imagine I have a fellow working under me who is actually better than myself. And in many institutions, this professor or this senior would not give this younger guy the privileges to grow. And so this person will run away or be very, very demotivated. So, despite all this, there is always a perspective, and healthcare education need more government focus in terms of regulation and governance. That's where we should begin. Secondly, we should work on public-private partnerships to learn from one another and to implement new ways of thinking in all our institutions. And that would mean that we need a change of the culture in a radical way. Because otherwise, we just keep doing what we are used for the last 30 years and nothing will change. And I think everybody is aware we need change. So everybody should be focused on how to bring change and how to do that. And finally, I think what is lacking in Pakistan also, and that could also be a level of change, is focus more on primary health care. That would take the burden from secondary and tertiary care hospitals, and maybe that gives some space to work on renewal and innovation when it comes to workforce and quality. So thank you. That is my 10-minute contribution, and I'm happy to answer questions later on. Thank you.